Hello, everybody. Thank you for joining me tonight. This presentation that I put together is titled The Practice Multiplier at the Center of Your Digital Practice, specifically using the Celea laser, which is a 9.3 wavelength CO2 laser. I've tried to kind of focus on how this laser helps to build and synergize with your other technologies that you have. I'm sure a lot of the people tuned into this webinar are probably heavy technology users already. They may do CAD CAM, they may have CTs in their office, and I've got all of that equipment myself, but I've also have a couple all tissue lasers, specifically the 9.3 wavelength CO2. And as far as I'm concerned, these things all come together to kind of synergistically boost your practice. We'll get into kind of numbers and things later. But I guess when I look back at all the purchases that I've made and the education that I've done, everything has been very additive. You know, there's one thing that I was chasing and I added that to the practice. Then I added another piece of technology and then I added another one. And then at some point, these technologies start to really synergize with one another. And for me, the third piece of that puzzle was the laser. So we're going to get into some clinical cases. We're going to get into some math. We're going to talk about efficiency gains that you get with the laser. We're going to talk about a little bit of marketing because there is some flair that comes with owning a laser and advertising that you have it. And then we're going to get to kind of just how do these things work together, and how at the end of the day, can you multiply your existing patient base, get more out of the patients that you see, and do it in a more timely fashion. So that being said, my name's Heath Brantley. I'm a practicing dentist in Wendell, North Carolina. It's a small suburb of Raleigh. I speak for Convergent Dental. I'm one of their key opinion leaders. I do basic training for people that end up buying the laser. I do some local CEREC training here with my Patterson branch. I have founded a learning center here about 4 years ago in Wendell. And I'm also the owner founder of Wendell Family Dentistry, which is where I do all of my dentistry. So the first concept that I want to throw out there is, what does all tissue mean? If you're like me, 7 years ago, I really didn't know what lasers could do at all. I had a diode laser that I kind of played around with, but I was never really satisfied with the results. I, of course, could only treat soft tissue with the diode. Certainly no hard tissue treatments were available to me, but, you know, it left a lot to be desired using that. I just didn't like how it interacted with the tissue. I wasn't that convinced that it was better than an electrosurge. And then I got introduced to this new world of all tissue lasers, specifically the 9.3 wavelength laser. And from then on out, I started treating teeth with lasers, and it's really changed my practice. When I say I treat teeth with lasers, I truly mean that. I am doing everything from just class 1s and 2s all the way through class 5, 6 cavities. I'm sectioning teeth with it. I'm doing tori removal. I'm pretty much any hard tissue, soft tissue in the mouth, I'm treating with the laser almost always. The burr still has a place, and, you know, it's like any tool in the toolbox. I just choose what's more efficient for the job. So the laser touches almost every aspect of my practice. There really are no limitations as far as what you can and can't do with it. More recently, you see here on the slide that there's a new sub-ablative treatment modality, which is where you don't want to necessarily ablate or cut anything, but you more want to shrink the collagen. And that kind of opens up the doorway for various sleep applications and reducing snoring and helping people to get a better night rest. So that's a fairly new thing. The laser actually didn't do that when I bought it, but through a software upgrade, I was able to add another procedure to the practice many years later. We're not going to get into too many physics slides here, but I do want to just point out that this laser, 9.3 micron laser, is specifically targeting hydroxyapatite. And you see on this absorption curve here, that if you could choose any wavelength that maximizes absorption in teeth, you would choose the 9.3. And that, didn't exist for the longest time, but probably about 9-10 years ago, this technology was invented. And, teeth is what general dentists typically treat. And so water, it also absorbs pretty high. It's not the highest spike of water, but fortunately, like I said, teeth are 97% hydroxyapatite in the enamel. So that's the molecule that you want to be targeting. As far as one slide on kind of blood vessels and bleeding, because lasers are used to stop bleeding as well. I want to make one important point, that this particular laser does not cauterize blood vessels. It more shrinks the collagen around the blood vessel, and that kind of squeezes the vessel shut, if you will. So you're not going to see like charring of the tissue like traditional cautery will do. And this graph is basically trying to show you that this laser is absorbed at a certain depth, which is deeper than a blood vessel's diameter. And because of that, you can cut soft tissue without making it bleed, because there's so much shrinkage of collagen around the vessel. This also is kind of a unique thing to this laser that I want to make sure I get to before the clinical slides. Out of all the lasers I've seen on the market, this is the most close to a regular setup as you can get to for a dentist. It has a variable speed foot pedal, which is by far the most important piece of this equipment as far as I'm concerned, because it makes it so natural to cut teeth. You push harder if you want to cut faster, and you let off the pedal if you want to go slower. And that, to me, that's very intuitive. It's very much like, the traditional burr and drill that I would use. And so that's worth mentioning, because other lasers don't have that. It's much more of an on-off interface, and you don't have any control. You have to stop what you're doing, change all your settings, and then go back to the mouth. Whereas this is very intuitive. You just let on and off the pedal. So that's very important to me. There is a whole lot of science that goes into this, but I think the primary reason a lot of you are on this webinar tonight is not necessarily to have a physics course given, but is more to just what's the real world application and how am I actually using this in my practice. And so, there's 4 primary things that come to mind. Efficiency gains is what we're going to focus on the most today. Something I didn't realize when I got into anesthesia-free dentistry was that when you don't take breaks, these natural breaks that we're all used to taking when we deliver the anesthesia and then we leave the room, your dentistry gets exponentially more efficient. If you can find a way to stay in the room, you will do way more dentistry, and that chair will be much more productive than having a patient sit there for 10 or 15 minutes at a time while you're doing something else, presumably more important. So this efficiency gain, there's also like new patients. You can't help but acquire new patients when you have a great technology like this. We'll get into some of the gains I made as a relatively newer practice, and all the patients who came to me just because they heard I had a laser. They didn't really know anything else about the practice yet. Also, for those who are kind of stuck doing the normal grind, which is just fixing teeth all day, I think if we all ran procedure code reports in our office, you would find that almost every code you run in your office is attributable to a tooth. So you do a filling on a tooth, you do an extraction on a tooth, you do a root canal on a tooth, you do dentures, you do all kinds of things, and 95% of your codes are tooth related. Unfortunately, tooth related codes pay very poorly. Soft tissue codes, which a lot of people are not doing, pay exponentially more, and they also are frankly easier to perform, and they take far less time than a traditional class 2 filling, for instance. But also you get better outcomes, which I know a lot of dentists, that's the most important thing. I don't want to do anything that's going to set the quality of my dentistry back. And if it's better quality and less invasive, I'm they're going to lean towards doing that. So in general, these are all four important things. They've touched the practice in different ways, but the most important thing by far is the efficiency gains that you get when you don't leave the room, because there's no limitations like anesthesia or bleeding that get in your way. So we're going to start with this case right here. It's a pretty classic class 5 lesion, tooth number 7. And you guys are probably thinking, there's a normal way that I would go about treating this. I'll let you think about that for a second. I'm going to go into how the traditional approach that I would take to this tooth versus kind of the newer age approach to this tooth. Okay. So your typical restorative visit starts with the whole get them in the chair, calm them down because they know the shot is coming. You're going to inject them. Then you're going to typically leave the room for some undisclosed amount of time. When you get back to the room, you're going to try to retract the gingiva potentially, or do a curettage or something to kind of access the lesion and see the full extent of the caries. Then you're going to prep the caries. Then you're going to have to control that heme that you just produced when you did the curettage because it was in the way. And that typically means you leave the room again. And then you restore the tooth at some point. In general, this probably takes between 25 and 40 minutes. I think the difference in 25 and 40 is based on whether or not the provider leaves the room during the coagulation step. If you take that second break, you are probably going to be closer to 40 minutes of chair time for this patient. And I do realize that that's not all doctor time, but it is time that a chair is occupied and an assistant is occupied with the patient. So I'm going to propose that the way we do this in a Solea anesthesia-free fashion is that we greet the patient instead of calming them, because they're not nearly as nervous for these laser visits as they are regular visits. We're going to ablate the gingiva away first so that we can actually see the full lesion. Then we're going to prep with the same tool, the same laser, the same power that we remove the gingiva with. And then we're going to restore the tooth, and there's going to be 0 breaks in this process. And for a class 5 lesion, like you see there, this one's probably closer to 10 minutes because it's a pretty big gingivectomy that we're doing. But for other ones where the gum's not as involved, it's probably a 5-minute procedure. So again, fewer steps, you're not leaving the room, which is the most important thing, and you're going to get a better outcome when you can control your soft tissue. Of course, this is a one-tooth situation. As you multiply this by full quadrants of dentistry, the benefits become more and more compelling. So here's our tooth again. For me in my practice, the first step is going to be remove the gum anesthesia-free, so that I can see what I'm doing. And that's what you kind of see here is the whole lesion outlined. You can see the white chalky enamel that wasn't present before. And now you have a good idea of how much you need to extend this prep before you start prepping it. This is what a laser-only cavity prep looks like. If you want to go in there and refine anything with your burr, you can certainly do that. So this is what the laser only looks like. It's a very kind of matte finish. It almost, it looks etched already, and it is laser etched, but it's had no phosphoric acid applied to it yet. Whether you kind of do that or not is up to you. For this particular person, I do not think that I applied any etch because I had good isolation and I didn't want to risk getting it on the soft tissue and maybe creating some heme to deal with. Now we've got the final restoration that's been polished back. And of course, with the burr, I've done a little bit of gingival curettage at this point. And we had a little bit of bleeding, but I wanted a post-op picture. So we applied some viscostat for the sake of photos. But obviously, if we weren't taking photos, we probably would not have done that. And the patient would just leave. So that's the typical, class 5 lesion. I've got a couple videos just to show how the laser interacts with the tooth now. This is a failing class 5 filling. you see the margins of the composite are stained, and then apical to the composite, there's some recurrent caries there. You always start with a nice outline form. I like this because you can see the computer controlling the little tiny beams on the tooth. I hope that's coming across on the stream. When you're in healthy tooth structure, you'll see the white light. When you're in carious tooth structure, you won't really see that white reflective kind of ablation that you're seeing there. So again, white is good. That means it's healthy tooth that I'm on. When it goes more into the middle of the cavity prep, it turns more almost like greenish with like less of that white flare. And so this particular one was pretty small. Fortunately, we didn't have to touch that gum, which looks very irritated. That gingiva may have bled, and we'll talk about that in a minute. Here's another gingivectomy. This is kind of an interesting one because there's caries here, but there's also an abfraction, which I didn't really know was there until I started ablating the gum away, and then you can tell it kind of just keeps going and going. So I think this was a situation where the patient had an abfraction, had some exposed dentin, and then they got caries. But you know, I went ahead and restored the entire abfraction lesion because I'm in there to fix the cavity anyway. And you can see how long this took in real time. I mean, this is about a minute procedure of prepping. And then normally no trauma happens to the tissue until you use a burr. And so you can just see we're trying to finish this back a little bit, and inevitably we hit the gum a little bit and we'll get a little bit of bleeding. And then some polishing steps. And again, one tool pretty much did all the work. And then we always bring our burr in at the end because we've got to do some polishing. One more case here of a class 5. You see that white sparkle? That normally means it's hard tissue. And we're just going to circumscribe the lesion a little bit on the coronal aspect, watching the color because that's very important. Then we end up having kind of a circumscribed lesion here with this island of enamel, I call it. I like to get the spoon in there. It's just very satisfying to scoop that out sometimes. And I'm also trying to figure out how, you know, how soft is this tooth? Is this going to be one of those caries that's kind of superficial, or is it going to be one of those real spongy ones that goes real deep? So that spoon kind of tells me that. Now that I've got a rough outline form of the tooth, I'm going to focus more on kind of caries removal. And you see how the laser's green right now. You don't see the white popping except at the edges. That means this is all carious tooth structure. And you just fan your tooth like you're painting a little bit, and you see the caries just kind of erase themselves as they get ablated away. Oftentimes we'll do a kind of a angle change here to angle it more in the long axis of the tooth and kind of get that most apical portion of the caries out of there. And then at the very end, we'll remove a little bit of that gum. This is where people would traditionally pack a cord or something right before they restore it. But you've got a laser with a variable speed foot pedal. So you just go ahead and remove the gum so that you can get a better access to restoring that. Okay, so these videos, real time on the right, I think it was double time on the left, but it doesn't take that long to prep a tooth. I would say typical class 5s like this are always under 2 minutes. I'm going to move on to something more like a class 1. This is kind of a interesting one because it hadn't actually cavitated yet, if you caught that. But now that we're cutting on this enamel, we're circumscribing what we think the lesion, extends to. And it only takes a few seconds before it starts cavitating in on itself, because the enamel at the kind of most severe part of this tooth lesion is very, very thin. So the laser was on there for like 2 to 3 seconds before we actually broke through to the lesion. Now we've isolated it. We got that little island of enamel. I like to flick that out again to check how soft the lesion is with the spoon. And then we go directly for the middle. So we start with a good solid outline form, and then we go for the middle, paying careful attention to the color of our laser. If it's sparkling white, it's healthy tooth. If it's just that greenish mute color, that means it's still soft. You still need to laser that part away. We've lost our tactile sensation, but we've picked up so many visual cues, it kind of makes up for that. So if you're concerned and you don't like the whole color tactile thing we were just talking about, you can always check it with your Explorer or Carey's indicator die. You're encouraged to, as a trainer, I'm always telling people just use the tools you're used to. Like, this should complement what you're already doing. It's not necessarily going to replace everything you're doing. So if you like Carey's indicator die, or checking your prep with a slow speed, or checking your prep with an Explorer, by all means, continue to do that. Don't trust the light, so to speak. But, now we've kind of transitioned into restoring this tooth. A little SDR flow, and we'll eventually put some heavier body composite in there. So now we've got a class 2 that we're jumping into the middle of. This particular lady is around 60 years old. She's got a failing class 2 composite on number 19. And we've already gone around the lesion for about a minute and a half, doing the same outline form that you've seen on the previous cavity preps. And we're just outlining it, trying to get to the bottom of the composite, basically. So the white is telling us that it's healthy tooth. So we know that we can lay off the pedal and not really remove a lot in that area. Now we're kind of pointing it down. This particular material, I think, was more like a glass ionomer type of silicate odor restoration, because it was significantly harder to ablate than regular composite resin is. And that's also why the color is a little bit off. But sometimes you attack these composites and you find out that they're an old silicate restoration, and you see it kind of flaking away there as it's kind of coming debonded. And the reason this video is in here is I want to get to the whole, you do as much of the prep as you can with the laser, but then you can finish it with the burr if you want. There's something called the analgesic effect, where when you've been on the tooth for about a minute with the laser, you can switch to your burr and do some minor corrections to your prep. So this normally includes straightening up your walls. I really like it for breaking contact, because you get nervous as you get closer to the tooth with the laser, the adjacent tooth, that is. But you switch to the burr because you think you have more control over breaking contact. And I still use my burr on probably 70% of these cases, even if it plays more of a minor role. So now in amalgam removal, because that's a common question, you can't really remove amalgam or metal. So you have to kind of do some tricks or some hacks to get around that. This is probably my favorite amalgam removal case that I've ever seen. A colleague of mine, Tim Anderson, posted 9 photos of the same tooth, and posted it on Facebook. And so I've kind of copied and pasted that here, because I don't have the patience to take 9 photos of the same tooth. And you can see the workflow that he utilized here, and it's the same one I utilize, which is to outline the tooth with a smaller spot size. So probably about a 0.75 spot was used here, millimeters wide spot, and you outline the filling. You also drop your box on the adjacent or on the opposite marginal ridge there. And then he elects to, and I'd sometimes do this, cut the filling in half with your burr, so that you see a little troughing inside of that amalgam there. And that does make these bigger ones a little bit easier to chunk out in 2 pieces instead of 1. And then what you're left with is whatever's underneath the amalgam, oftentimes liners and a lot of stain, caries probably if you're replacing it. And you can see here he's done that with the laser and then restored it. So here's a couple of my amalgam removal videos. Again, show a little bit of troughing on this big one. This one's a little bit more interesting because It's not like a traditional MO. It's got that big buckle component to it. So at first I wasn't really thinking. I went in here and tried to kind of pry it out that way. That's not probably going to come out that direction. And then finally I wised up and thought, why don't I just go at this from the buckle so it has a free path of removal? And you can see it kind of move there for a second. And then I go right here and try to slow-mo it because it was fast. It just whipped out of there. Okay, so same situation. Now we restore it. This is also anesthesia-free. You can do it anesthesia-free. What I tell people all the time is, practice dentistry the way that you always practice. So if you're more comfortable numbing every patient, still you can use the laser. Maybe you numb this patient and you immediately go to town with the laser while they're getting numb, because the laser provides so much less stimulus on the patient. They've got 2 or 3 minutes of that troughing for the anesthetic to kick in. And then you can go in there and switch to a birth if that's kind of how you prefer to remove that. I've got one more. This is maybe a little more what people are ready to do. That other one was a little bit large, but same situation. You trough it and then you prep the opposite marginal ridge, assuming that's where the caries is. And you're trying to mostly break contact. Like I said, I like to break contact with a 245. And here I'm trying to get it out in one piece instead of making that trough in the middle. And you see part of it kind of chunked out. And of course, be careful. I'm not in there using like elevation pressure as if you were extracting a tooth. Certainly, you could probably damage a cusp if you're applying too much force. But, if you go in there with a little bit of force and then you see some movement, you know that it's going to come out. So we talked about kind of being more efficient because we take the stopping and starting out of dentistry. And traditionally, blood and needles are what make us start and stop the most. We didn't necessarily talk about 4 quadrants of same-day procedures, but you could probably imagine that there's certain limitations to numbing the whole mouth. It's not that pleasant for patients. Also, we can potentially get into some max dosage situations on young kids, for instance, with local anesthetic. So, a lot of times we just do 1 quadrant or we do half the mouth at a time. But with anesthesia free, now the whole mouth becomes a target, and we can do that safely and efficiently. We talked about adding some new procedures. So far, you guys have probably all done fillings like the ones you've seen so far, but maybe soft tissue is where you're going to add some new procedures. And then patients just love the fact that you sit down and get to work on them. My best compliment I think I've ever gotten for the laser was, wow, you just sat down and got to work on time, like my appointment time, and you didn't have to leave and attend to somebody else while I sat here and waited for you. So those kind of things are important to some people. And again, the laser is going to mean something different to everybody, including your patients. They're going to have something they like about it. But, to sum this all up, I've got this video that I tried to shoot and create where I did the same patient, same normal workflow. I asked my assistants to kind of keep me honest on things. And so I basically entered the room 2 different times as if it was 2 different appointments. And of course, I told the patient what was going on. I was just shooting a video to kind of demonstrate the workflow difference when you have a single class 2 that's taking up about 40 minutes of chair time. And I did it with a handpiece on 12DO, and then I did it with the Celea on number 4MO. So very similar procedures. And I'm just going to show you kind of the side-by-side test here. So of course, the patients are seated about the same time. You'll notice that the first thing that happens in this video is, 1, the topical goes straight into the mouth of the person that's getting numb, because my assistant is explaining what's going on that day, and I'm normally somewhere else doing something else. because I know that topical has got to sit for 3 to 4 minutes before I even get in there. And I know that they're doing blood pressures and various other things too. Whereas on the laser only procedure, you see that I walked in pretty much immediately because there is no downtime during this situation. The Leanne is my assistant here. She explains what's going to happen and basically gives me a nod, and then I'm in the room. I also come in and I'm giving about a 1 minute spiel on how the laser is going to go down. I'm talking him through, what to expect, the cold sensitivity, all that. One thing for laser patients is because you're not totally knocking out all sensation, they will oftentimes still feel some cold. And so you want to tell them that they're going to feel cold. Here we get to work. I popped in the room for a second to numb the patient, and you see now I left, and it's been about 12 minutes before I come back in. Meanwhile, we've prepped and restored the laser filling patient, and he is on with his day, really not, thinking anything happened. His bite is perfectly fine. He can tell because he's not numb. Our incidence of post-op discomfort is significantly lower in these situations, so I don't have to do a post-op after the fact. Now you notice I've prepped again, and I left the room and thinking my assistant takes this long to put a band and wedge on, but the patient just sits there with his mouth wide open with a dry shield isolated, which is, I just don't know, looking back, it doesn't seem like good customer service to me to have somebody's mouth gagged open like that when you're not actually working on them. So this is very much everyday dentistry for me. If I was running 2 or 3 columns at a time, or I had a lot of hygiene checks to do, the average single visit class 2, when I can't utilize FDAs or anything like that, it's going to take me 40, or it's going to take chair time of 40 minutes. Whereas this procedure with the laser is going to take more like 12. And again, this brings up the concept of chair time versus doctor time. A lot of us have maximized doctor time, like we're very good at that. We're always trying to be productive in our office, and we don't want to sit around twiddling our thumbs. But a lot of people are struggling because they've maximized their chairs, and they need to either upgrade and get more rooms built out, or they just need to make their existing rooms more efficient because the doctor doesn't leave. And so I would argue that a 12-minute filling is infinitely more profitable than a 40-minute filling for that particular chair. So now we're going to transition into some soft tissue applications, because this gets to the whole adding new procedures, which is important to multiplying your practice. And so I'm particularly intrigued by this internal study that Convergent Dental did, where they polled their existing users, whether it's like 3 months of laser use or 5 years of laser use. And they basically said, can you, on a scale of 1 to 5, tell us how long or how easy it is to do dentistry the traditional way when it comes to like 30 different procedures? And then they also asked about kind of what is their fee per hour for how long it takes to do those procedures. And this is the result of that study. And so the bigger the circle, the more of those procedures the provider does. And as you can see, class 1, 2, 3, 4, 5, those are huge circles, because again, that's all dentists do. Like if you run your numbers, almost everything you do is probably one of 5 procedures. It's a crown, it's a filling, it's a extraction, it's a denture. Like it's the same 4 codes that you're basically running all the time, 4 types of codes. They're tooth related codes. And obviously you're doing very little soft tissue. That's why their circles are so small compared to the restorative codes. So also notice that if you're maximizing your efficiency as a general dentist doing it the traditional way, you're probably producing about 1,000 an hour. Notice how all these procedures are very they're hovering over that $1,000 per hour production. No matter what you're really doing, because that's the survey. Now, some things like the class 2, as you can see, that's actually the least profitable procedure in dentistry according to this survey. where you can see the class 2 is ranked at around 500 an hour. And I think that makes sense to me based on how I used to schedule and how I know dentists tend to schedule 2 to 3 class 2s in an hour. Again, they're not in there the whole time. They could do it faster if they didn't have to leave, but they leave and there's all this dead time. Like in the last video, there was at least 23 minutes of dead time during that procedure. And that causes your chair time for the class 2 to be half as productive as it really needs to be. So then they contrast that with when people moved to the Celea or the CO2 laser, and then they had some more flexibility to do things faster, to schedule a little bit differently. And then they noticed that all these procedures moved to the right and they moved up. So things got easier, but they also got more productive because they took less time. And so to me, this is probably the best graph I've ever seen that I don't know the right word is personifies work smarter, not harder. Everything moved to the right and everything moved up as far as fee per hour goes. And we'll get into some of these numbers a little bit later on, because this is the kind of stuff that was secretly happening in my practice and I was totally unaware of it. It just I was enjoying practicing dentistry. Everything was fun. I just liked using the laser. And then I saw all of this productivity gain kind of on the back end, which was like, super exciting because I wasn't necessarily expecting it. But, it's nice to provide the dentistry you like to provide and also get rewarded for it. One thing that I do want to point out is how high gingivectomy and frenectomy and excisional biopsies, look how productive they got. They basically became extremely easy to do, and they're billing out at roughly $3,500 an hour. And that's because like an excisional biopsy takes like 10 minutes or 8 minutes, and you can charge $500-$600 for it. That is not how those things are traditionally scheduled, though. They're more like 30, 40, 50-minute appointments because of the numbing and the heme control and the stitches and things like that. So what do we need to do to try to get into this so-called transformation zone, as Convergent Dental calls it? We basically just need to make dentistry easier, and we need to focus on soft tissue, which is what this next session is about. Soft tissue pays extremely well compared to hard tissue. So here's a classic gum lift patient. We call this a gingivectomy in the dental world, but like to patients, I call it a gum lift because it sounds better. You can simulate in 1 minute on your iPhone what a gingivectomy would look like on a patient like this. And it's very important to use her face and her photo because she knows that's her nose ring. She knows this is what her teeth could look like. And when you have her engaged and she wants to get this done because of your simulation, that's when you go through the work and you do all the treatment planning, getting all your records that you need, your x-rays, your probing depths, your photos. I do a CT so I can look at the bone levels and stuff. That's when you do all the work, is after you get her to say yes to her teeth looking like this. Okay. So for her case, I use a Thompson marker just to kind of roughly gauge what 2 millimeters would look like. Certainly you can freehand this, but the most important part is like treatment planning it correctly, knowing that you're not going to find a CEJ, and knowing where her bone levels are very important before attempting this. So here I did like a right side, left side kind of look, and you can see that we move the gingiva up approximately 2.5 millimeters. And then we also kind of did festooning of the gums, if you will, to borrow a denture term. But that's kind of unnecessary. I did that primarily because she did have a chief complaint that her gums were not only long, but they were thick. And, after doing several of these, I quickly realized that biotype, that thickness of the gum is going to come back every time. So ablating away some of that, or that festooning that's more apical to the actual gingivectomy that was done, is unnecessary. It's going to cause some, a little soreness that's just not really beneficial to the patient when it grows back again. So this is what she looks like immediate post-op. You can see she got all that ablation done to fix the thickness of her gums that we were talking about. And after 30 minutes or so, this stuff starts to ooze, is what you're seeing here. And again, that oozing is totally unnecessary if you just focus on the gingivectomy part and avoid the festooning. But this is how she finished up. You see the middle picture here is the 2.5 weeks mark, where the gums are still immature and they're healing. And then you see more of a 6 weeks look where the gums are healed now. And, you know, she still has a little bit of gingivitis. She's still working on her brushing. Here is the way that you should probably do the gingivectomy when you start doing these. And it's, you know, you draw freehand. In this situation, I didn't use a Thompson marker, and you just make the same outline over and over again. And this is more of a gingivectomy than a gingivoplasty. And then when you see that you've made it all the way through, you just remove that little piece of gum. And that's an anesthetic-free procedure. You do some topical only. This person's not going to have any of that oozing that you just saw the previous patient have, because we focus on just a very clean cut on the gums and not ablating all that other keratinized tissue up there unnecessarily. Another procedure that's, again, soft tissue related and is picking up steam is gum pinkening. In the laser world, they have traditionally called this depigmentation, but I find it hard to talk to patients about depigmenting their gums. That is a very hard concept to talk about. Gum pinkening, like gum lift, sounds more easy to them and less kind of invasive. So I go with the term gum pinkening now, and I know that there are people that are starting to market this procedure more often. But of course, this is for individuals who have darker melanin. Traditionally, this would be Black people or Indian people. They're primarily the ones that I've treated with this procedure. And basically, there's a hyperpigmentation in the outermost layer of the epithelium. And so these melanocytes, you know, produce melanin their whole life, and it all floats to the top. And then you see the deposits kind of on the outside there. So this procedure is done in a few minutes, and the patients are really thrilled with it. It typically lasts for a couple of years. I'm telling patients up to 3 years, even though people can get a little bit longer out of it. I just would rather it be 3 and meet everyone's expectations, because those melanocytes are still working all the time, and they're producing more melanin for this individual's whole life, and it's always going to float to the top. So you're going to have to get retreatments over the years. So here we're going to show you what this kind of looks like. This is a very superficial procedure. We're talking about removing about 1/10 of a millimeter of that epithelium, and the hand motion is very fast because they're not numb. And the faster you move, the more comfortable it is. And you're just erasing the top layer of epithelium. That's all it is. And you kind of just go as slow or as quick as you want to go. But, you know, I'm kind of testing the waters with this patient, seeing how they feel things. And if she's doing well, I'm probably going to get more and more and more aggressive so that we can just move faster. So now we've got this going, you know, triple speed or so. And it's just a very visual process. If you feel like this is too invasive for you as a clinician, you could always do kind of like one step and tell them you're going to bring them back in 6 weeks and do some touch-ups. But, you know, for me, I like to get as much of it done as possible at the first visit, and then maybe avoid having to do this again for 3 more years. And then we talk about add and fibroma removal. Quick story on this guy. He came to the practice one time. I've only seen him once, and it was for an extraction of number 3. No, it was number 14. Number 14. And while he's getting numb for 14, I asked him about the fibroma on his tongue, if it bothers him. And he's like, not really. I kind of made a joke about it. And then I was like, would you want it removed if I didn't have to numb you? And kind of, it was just a real simple 30-second thing. And he goes, sure, I would love that. It gets swollen from time to time. I don't like it. So while he's getting numb for number 14 extraction, we just remove a fibroma. And so you can see here, the assistant's got the HVE on the opposite side of the laser so she can quote unquote catch the beam. Because if I do end up shooting past the fibroma, it'll hit what's on the other side, which could be his lip or something else. So she's there to kind of just absorb that blow. And she's pulling pretty hard. You see it blanching. But this is a topical only procedure. The key to these is just big tension. And if anything, your assistant doesn't pull hard enough, and then the procedure kind of slows down a little bit when they're not pulling hard enough, because you really need that to be super tight, and then it just pops off. So we do the extraction for like $200, but we also remove the tongue lesion for $500. And as you probably know, the the extraction took way more time than that did to accomplish. Here's another large one. This one got numb. Again, these doesn't matter to me whether you numb these people or not. If they're very needle averse, then I'm not going to numb them. If they don't care about the needle at all, then I might numb something this big on this sensitive of a body part. But when they're numb, you can also go much faster. You see how quickly that went. Fibroma removal, this is what the healing looks like. This is a different case, but you can kind of see immediate post-op. It just looks like a little abrasion wound, like it's just sandpaper or something, not bleeding. And then 7 days later, it's pretty much closed. It kind of looks like an ulcer, but it's not really an ulcer. It's just immature tissue trying to heal itself. Then frenectomies would be probably the next low-hanging fruit with soft tissue. I used to not be that aggressive about treating them because my modality was, difficult for the parents to really accept. But when I moved to kind of this laser modality where there's really almost no bleeding, the anesthetic required is minimal. You can kind of see here, that's what a typical frenectomy looks like. We got one more here. I just only have time to show maxillary frenums today, but there's a lot of tongue-tied individuals that would benefit from a similar procedure. But you just see how the tissue melts away, and you get that classic diamond appearance, and you just see the fibers melt when you use the laser. And the whole time you're just feeling tension, trying to decide how much to do. I like to just not feel tension. So if I stop feeling tension, I will stop cutting. But if I continue to feel tension, then I will go down and score the bone, which in this case, I think was needed. You see that really thick, fibrous, yellowish white fascia tissue there, right in the midline. I think we're going to highlight it here for you. I really want that severed personally. I just think there's a high recurrence rate if we don't get that severed. So then I try to go in with my laser and just aggressively just cut that. When you start getting to that level, I prefer the patient to be numb. But like I said, they don't need that every time. So I'm going to go to some healing slides here. You'll notice that like these things always heal exactly where you score it at. And I think in the middle picture, you can kind of see in the middle where it's a scored line on that immediate post-op. And that's exactly where the scar and where the attachment ends. It does not reattach near the papilla when you do it that way. So you guys remember this graph, and you remember that using the Celea moves everything. And so there's a couple things that I want to point out, which is gingivectomy, excisional biopsy, depigmentation or gum pinkening, as we call it, frenectomy. Those things all moved very substantially. They moved basically all the way to the 5 extremely easy category, but they also, because of how fast they are done, they go up to the $3,000 per hour type of rate because of the time that they take. So a gum lift may be charged at, depending on how many teeth, about $1,000 to $1,500, and it takes about 25 minutes to perform. So you can see how the math, you would double that, and you would get somewhere between like $2,500 and $3,500 to do a gingivectomy. Gum pinkening, I don't charge a lot for that right now, but it takes about 30 minutes, and it's becoming more and more popular in my practice. The more patients that have had it, the more they're talking about it, and more people are asking for it. Fibromas, those are super fast. I mean, you saw the one that got numb. I mean, that thing was done in like 20 seconds. They're very profitable procedures. And the frenectomies, same thing. You're going to start treating all kinds of kids, infants that take 30 seconds to perform versus 7-year-olds that might take 5 to 10 minutes to kind of get them numb and perform the procedure. And then I did want to throw in here that the focus on the fillings, because we're all doing fillings at the end of the day. Most general dentists still have those, and those are not profitable. One filling in 40 minutes, maybe it's $250 in production versus like doing a 15-minute filling. Like that's basically making your fillings produce about $1,000 an hour for you. And that's significantly different. And so all that is happening when you have the best tools for the job, and you get to pick what makes you most efficient out of each chair. I did want to mention pediatrics because that was probably the biggest unforeseen thing that happened to my practice, because I didn't like treating kids before. There's very unpredictable, but now whether I use nitrous or not, if they're a pretty compliant kid, we're routinely doing full mouth pedo, just 8 class 2s in an hour all the time. And that's one of the most profitable things in the practice. Also some like little add-on things here, like you can remove veneers with this thing. Like really, you get creative when you have this tool in your room and you're already using it. Like I know I'm going to be replacing this veneer, so I'm going to have this layout at a bare minimum, the trough around it for my impression. But why not just remove the veneer with it, which, this is an Emax crown, I believe. The laser performs better with Emax and feldspathic porcelains. It's not as good with zirconia, but you can see there removing it. We trough around crowns. We accidentally, touch the tissue, and you can clean up around your crown, any place that you may have nicked. Not cauterizing the tissue, but just squeezing those vessels shut long enough to get your impression. And then, no time to really talk about this case. I just have a before and after, but when you can control the soft tissue perfectly, you can go from this really horrid situation that would ordinarily take 3-4 visits or more to this in 2 visits, because you can control the soft tissue. Obviously I have to have CAD CAM, I have to have CT, I have to have my Celea for this, but without those things, there's no way that case gets done. So to end on a high note here, I just want to go over what's happened in my practice over the last several years. I made this particular slide when I was 2 years into Celea. Since this time, I'm 3 more years into Celea. So July 17, it was just me, 2 hygienists, 6 of us on the team. That's pretty classic, right? I buy the Celea. Immediately in August, my new patient flow jumped 38%, and nothing changed except buying the laser. We fast forward to May. I'm so busy, I have to get a full-time associate because I can't do all the work. I go from 5 clinical days to 4 clinical days a week. Go to July 18, which is exactly a year after my first Celea, and I have to get a second one because my associate sees the value and he's wanting to use it all the time. We hire more team members. the practice is up 60% from the previous year. Okay. Associate's only been there 2 months of this. So it's not because the associate started that we're up 60%. It's we were already growing and exploding with these new patient numbers and getting more efficient with our dentistry. So then October, of course, they released the Model 3, which I'm a little bit, like I just got a second Model 2, but it's all good. I had to get one. And then January 2019, we have 14 team members. I got another associate that's hired. And then I go down to 3 clinical days a week. So you're starting to see where I kind of go with this. July 2019, practice has doubled in 2 years since getting the Solea because of the boom that happened with new patient flow and efficiency gains. And then I'm a happy camper, right? Super happy. Things are going well for me in the practice. Then 2020 comes along. This is where I've updated the slides because that was, of course, a weird year. And we were mostly flat. So basically no growth that year. If anything, we were just slightly down because of the few months of slowness. Then 2021 to 2022, like 2 more years post-COVID, basically. And now we're up to 20 members, team members from 14. We're up another 54% from where we had already doubled. And then 2023, our pediatric dentist actually starts tomorrow. So we basically, because I started seeing kids again 6+ years ago, we built a mini pediatric dentist office within a general office. And my pediatric dentist actually starts tomorrow. So we get to see in future years what growth comes out of that. But in general, over the last 8 years of practice, owning the Solea for 7 of them, we've grown from 4 team members to 20, and we've grown our revenue 7 times. So again, I'm proud of that. I attribute it to these things. Procedures are quicker, or marketing like the laser, and then people aren't scared to get their work done. All of that's super important. But, I decided to grow that way. Other people don't want to grow that way. They just want to maybe work fewer days, which you can do, and keep everything the same. You can change your schedule. You can do the same amount of work in 6 hours instead of 8. It's whatever you want to do with yours. I just decided to scale and grow the base of patients around me. But, this technology allows you to multiply your practice however you see fit. So with that said, I hope I finished close to on time. And I think we're going to do question and answer now. So there's a question about sensitivity with patients. You learned this in basic training. Everybody is different, and there will be some cold sensitivity for sure. And deciding which patients you should and should not do this on is definitely a case selection type thing. I've got about 7 rules that I go through during training that help you identify cases that you will most likely be able to do anesthesia free without any sensitivity. But I would say, as it boils down in my practice, I choose about 70% of my patients to do anesthesia free on, and I'm about 95% correct on those. The other 30%, I don't give my patients an opportunity. So I just numb them the traditional way. That could be a dentin hypersensitivity patient, or one that I anticipate maybe endo is needed on. So, those people I'll go ahead and numb because I don't want to surprise midway in the procedure. So it took me probably 3 to 6 months to get super comfortable with it. I, of course, was happy in the first few months, but I was only doing baby procedures. I was doing little class 1s that I could visualize really well, class 5s that I had very good visual access on. And then at some point, I got more and more confident where I'd do bigger ones, or I would do amalgam removals. So that took me up to about 6 months. Also, learning to trust the burr was important for me. So breaking contact, I like to use the burr because it's more predictable. But the first few months, I was a little scared to use the burr because they weren't numb, and I didn't trust that analgesic effect. So then I did get it. And I like trusted it and I decided to use it. So I think I answered this question about giving local anesthetic for class 2s. It just depends on the patient. If they're comfortable and relaxed with no anxiety, you really are going to have a good anesthetic free situation. But if they're like super amped up and they're even making you a little nervous walking in the room, I would just numb that patient. Because at the end of the day, you have to do what makes you the most comfortable so you can get the best outcome. I personally don't do any stitches or sutures on maxillary frenums like the ones that were shown today in the lecture. There are some situations on the tongue where I still may place stitches. So the laser is actually great for going into the pulp. It's going to ablate the pulp very nicely as if it was like soft tissue. So if I chase the caries all the way into the pulp, so be it. At that point, we're probably doing a root canal, most likely. If it's a tiny pulp exposure, we might be able to get by with some direct pulp caps and stuff. But either way, pulping a tooth in a fully pristine, isolated environment with the laser is much better than pulping a tooth with a dirty burr. And so that pulp has a better chance at maybe not needing a root canal. The handpieces never have to be replaced, but the mirrors do. So there's like a little gold mirror attachment on each handpiece, and those are supposed to be replaced every 200 uses. What I have found is I just replace all my mirrors and my 3 handpieces every 3 months. So that's kind of like the normal flow to get maximum cutting and maximum adverse reactions because you're using an old dirty mirror. I personally think that there's much less aerosol when you use this. Most of my work is done under a dry shield, which reduces aerosol by 90%, that step alone. But you are technically using significantly less mist with the laser. You're probably using around 11 to 13 milliliters of mist per minute with the laser, whereas a lot of studies show that traditional handpieces are anywhere between 30 and 45 milliliters of mist or water per minute. So it is much less water that you're introducing into the environment. My assistants noticed that too. They have significantly less suctioning to do when I use the laser. So I cut my time to 3 days primarily to scale the business. When you're in your business working 5 days a week, there's not really a lot of time for management because you're just spinning your wheels all the time. But because I was hiring other dentists and our business was growing, my time was better spent focusing on bigger picture things than sitting in the chair. So the laser is very safe to use near the pulp. It's not creating any more heat than a drill would. It actually produces less heat than a drill does, assuming everything is irrigated. And so I have had far better pulpal outcomes when using the laser than with the drill. Way less pulpitis after the procedure and fewer root canals after I do a filling. So there's a question about doing a pulp cap with the laser. You can remove part of the pulp with the laser, but as far as a material, the laser is not necessarily going to be a pulp cap type material. It'll help you get to the pulp and kind of sterilize the pulp where you're hitting it, but it's you're still going to use your traditional restorative materials for that. I definitely use the laser every time to trough around the crown. I no longer use cord. All right. And I think that is it. We're out of time. I tried to get to as many questions as possible. I know there's some that I didn't, but I kind of rapid fire answered all of them straight line as I was seeing them. Sorry if I did not get to it, but I enjoyed today, and thank you for taking time to listen to me talk about the growth of my practice and how the Celea has helped me to multiply my practice.